Hemant, Prashok, hi.
Hi, I
Yes, sir. Can we start, sir?
Yes, Dinesh.
Yeah.
So this is Vikram this side. If you can just put your presentation live.
Good evening to one and all. At the outset, I would like to extend a warm welcome from the house of Lupin Respirators, the makers of Easy Flow. Today we have Dr. Murli Mohan, who will share his wisdom on topic integrated care for COPD patients with cardiovascular comorbidities. Before move on the presentation, it's a pleasure to introduce the speaker. Dr. Murli Mohan was graduated from Bangalore Medical College and MRCP from the Royal College of Physicians, Edinburgh. He trained in respiratory medicine at Nine Wells and King Cross Hospital, Dundee. He subsequently took his specialty certificate examination in respiratory medicine from the British Thoracic Society and the Royal College of Physicians of UK. He was awarded FRCP by the Royal College of Physicians and Surgeons of Glasgow. His keen interest areas are obstructive airway disease and interstitial lung diseases and pulmonary hypertension. And he has presented more than 30 papers at various international and national conferences and also in international journals. Dr. Murli Mohan is the joint author of WHO Manual on Tobacco Cessation for Medical and Dental Professionals. Also, he also heads the Nightingale's Life-Saving Services, which has trained over 30,000 persons in CPR in Bangalore. Currently, Dr. Murli Mohan is the Senior Consultant Pulmonologist and Director of Department of Internal Medicine and Pulmonology at Narayan Hridayalaya, Bangalore. I welcome Dr. Murli Mohan, sir. Over to you, sir.
Thank you so much. Thank you for inviting me to talk on a subject that, is actually very close to my heart. When I started out after my post-graduation, moving to the super specialties, I actually initially wanted to do cardiology. But then later I found respiratory medicine even more fascinating, so I moved to respiratory medicine. I also work at Narayan Hridayalaya, one of the largest and busiest heart hospitals in the world. So I tend to see a lot of this combination of COPD and cardiovascular disease. So when I was asked to talk on integrated care, COPD patients with cardiovascular comorbidities, I jumped at the idea. If you look at the leading causes of early death globally, in 1990, COPD hardly figured anywhere in the list of the top 10. In fact, it came 11th. Ischemic heart disease was 4th on the list. Just 27 years later, globally, ischemic heart disease has moved to the 1st place, and COPD has moved to the 7th place. And in fact, in 2020, it's in the 3rd place. But you looked at India, ischemic heart disease and COPD occupy the top 2 positions in the leading causes of deaths and disability-adjusted life years. So if you look at the global burden of COPD, India's contribution is huge. The prevalence, we are contributing about 1 in 6 cases. But you look at deaths and disability-adjusted life years due to COPD, we are 2nd in the causes of deaths, and in DALYS, it is the 1st, which means we're not doing very well. We have 1/6 the prevalence, but we have 1/3 of the total cases for deaths, disability-adjusted life years. So it's a huge burden in India. If you look at the risk factors that cause early death and disability, overall, among men, smoking is the topmost. And among both men and women, high systolic blood pressure are extremely high on the list. So the leading global factors for early death and disability in both genders are smoking and high systolic BP when you combine both genders. And one of the things we know is that these are the important causes of not only COPD, but also of congestive heart failure, coronary artery disease, atrial fibrillation, name the cardiovascular disease, and these 2 risk factors, smoking or other tobacco use, and high systolic blood pressure figure very high on the list of risk factors. Now, if I ask you, is COPD a lung disease? Obviously, the answer is yes, very, very obviously. But there's another question to ask. Is COPD only a lung disease? And I think the clear answer is no, it is not only a lung disease, it's a lot more than that. And if you look at the publications on comorbidities of COPD, you can see that since the 90s, there has been a huge surge. Before 1991, using the PubMed search term COPD and comorbidities, I was able to find only one publication. Between 91 and 95, it went to 42. Between 96 and 2000, it went to 289. And since then, there's been a huge increase. We're not even at the end of 2020, but from 2016 to now, there are already 24,000 publications. So the number of publications has increased exponentially, or even more than that, since the mid-90s at least. And my interest in this, why I started doing this search, was one of my favorite patients, a wonderful person, Mr. P, I shall refer him to, about. He had severe COPD, but you can see the list of conditions he had. More than 11 additional comorbidities. And I was wondering why one man should have so many problems. My colleague in cardiovascular and thoracic surgery often refers to the term poor protoplasm. But I didn't think this was poor protoplasm. This man was elderly and he'd had a wonderful life. His only problem was he smoked, but he exercised regularly, led a very, very full life. And then I started reading more about COPD and its comorbidities and found that these are the described comorbidities: cardiovascular disease, a variety of them, but also osteoporosis, anxiety, depression, lung cancer, metabolic syndrome and diabetes, GERD, bronchiectasis, and obstructive sleep apnea, all of which have been shown to have a significant association with COPD. We're not talking about a cause-effect relationship. We're just saying that COPD coexists with these conditions, and that is the definition of comorbidities, a condition that coexists with the disease of interest, in this case, COPD. So when I look back at Mr. P's problems and look at what has actually been described as being a recognized comorbidity with COPD, you'll find that quite a few of them qualify: coronary artery disease, peripheral vascular disease, anemia, osteoporosis and osteomalacia, depression, being underweight, what is called sarcopenia, and being colonized with bugs, including Pseudomonas. One of the other things that is increasingly being described is old heel tuberculosis, which he'd had. And now we refer to the term TOPD, or tuberculosis-associated obstructive pulmonary disease. Why do patients with COPD develop so many comorbidities? There are many possibilities. One is it could just be COPD is a common disease. These diseases are common. They are bound to overlap in some way. So is this just an epiphenomenon due to the frequency of two diseases? Is it due to the treatment we give for COPD? For example, we know that steroids can cause diabetes and osteoporosis, and a lot of patients with COPD receive steroids, both inhaled and sometimes systemic. Is it because of a common cause? Is it their lifestyle which has caused COPD and, for example, cardiovascular disease or stroke? Is it smoking that initiates both these? Is it indoor air pollution and other noxious fumes? Is there a common underlying pathogenetic pathway that leads to COPD on the one hand and to CVD on the other hand? And I'm going to race through this because I think it's fairly clear that the last two are the important. It's lifestyle, predominantly smoking and other noxious fumes, and a common pathogenetic pathway characterized by inflammation that leads to the heart problems, that leads to the lung problems, and also to other organs getting involved in COPD. It's unlikely to be a disease just occurring by chance. So you find that, when you look at conditions like asthma and diabetes, diabetes does have comorbidities, but far less than in COPD. And as one grows older, COPD is almost always associated with more than one comorbidity. As you see, the dark blue has 3 or more comorbidities, and you can see in 45 plus age groups, often there are 3 or more comorbidities, just like my patient, Mr. P. 2 occur in quite a few, and most patients have at least one. Practically nobody with COPD has COPD alone with no comorbidities. Diabetes, on the other hand, quite a few have just diabetes, and more have just one comorbidity, and very few have 3 or more comorbidities. And this is true whether you're looking at asthma or arthritis or cancer. Most people with these conditions have either a single or one comorbidity and not more than that. There's something special about COPD. And you look at the risk ratio, condition like asthma, where we use steroids more commonly than in COPD, we use larger doses of steroids than in COPD. You can see most of these conditions, except for cataracts, are far less common in asthma than in COPD. So comorbidities characterize COPD even when compared to other conditions where steroids are more commonly used. So it's clearly not just an epiphenomenon, two diseases occurring together. It's not due to the treatment we use. It is due to common causes and an underlying pathogenetic pathway. And we look at noxious fume exposure, we find this in people who've never smoked. Tobacco smoking increases the risk of COPD by 2 to 3 times, but not all smokers develop COPD. Only about 50% of smokers develop COPD. And there are different forms of tobacco use, apart from cigarettes and BDs and hookahs and chillums. You have also other non-tobacco associated things, indoor air pollution, commonly associated with so-called non-smoking COPD, highlighted by our dear colleague, Dr. Sandeep Salvi, who's done a lot of work in this area. And in fact, this slide comes from him. And various other things, including mosquito coils and so on. Outdoor air pollution is another major factor, and the use of other religious things like agarbatti sticks and so on. What do all of these produce? They produce tobacco smoke or other fossil fuel fumes. And what do these induce? They induce oxidative stress. They cause an increase in the circulating cytokines. They evoke the production of acute phase response proteins. And there's a whole host of activated circulating inflammatory and other immune cells. What is oxidative stress, which is caused by these humoral and cellular elements cause? They cause airway damage, but they don't only cause airway damage. They also induce changes in circulation. They cause cancerous changes in the epithelium. They cause atherosclerosis. And most importantly, they contribute to the systemic component of inflammation that leads to problems in all systems, leading to the comorbidities we've already discussed. Where do the mediators come from into the airway and the systemic inflammation? They spill over from pulmonary sources, but there are also systemic sources. There are circulating blood monocytes, there's striated muscle, and there are concomitant atherosclerotic lesions, which lead to problems in all organs, because all organs have endothelial lined blood vessels. So if you look at the pathogenesis, the flow of events in COPD, it starts with noxious fumes. There are various amplifying processes which involve the immune system, which involve oxidative stress, and various humoral and cellular factors. And underlying all these are genetic and epigenetic factors. These work through cellular processes and humoral processes. There are a variety of pathological processes that cause changes in the lungs in the top half of the fourth column. And these classic changes that we see in COPD are also associated with changes in the other systems, atherosclerosis, lung cancer, the metabolic syndrome, and cardiovascular disease. And the clinical outcomes of all these take a person to move from asymptomatic to mild problems. Exacerbations occur, pushing him into more severe problems and leading to gold stage 4 or now gold stage D. And that finally culminates in death. So because we have this enormous contribution of systemic inflammation, two of the world's leading researchers and clinicians in COPD, Laurent Fabry and Klaus Rabe, proposed, slightly tongue-in-cheek, that instead of calling it COPD, we should call it chronic systemic inflammatory syndrome. And why is this? Because you have a whole host of comorbidities, as we mentioned earlier, but a variety of them are non-cardiovascular. I'll be focusing for this talk only on cardiovascular risk factors and comorbidities that accompany COPD. And I've turned that slide on its right and focused only on the cardiovascular comorbidities and risk factors. And you can see that hyperlipidemia, occurs in or more than 45% of the COPD population, hypertension in almost the same number, and it ends with ischemic heart disease and heart failure. Diabetes is common in diabetics and another population. Various arrhythmias, characteristically atrial fibrillation, strokes, aneurysms, and even the venous compartment with DVT and pulmonary embolism are commoner in patients with COPD. The mortality risk, as this slide shows you, increases hugely. Ischemic heart disease and COPD have interactions. And in a patient with COPD, I'll just focus on ischemic heart disease, but the same is true for all the others. If you look at COPD, the hazard ratio for having ischemic heart disease and dying of ischemic heart disease is anywhere from a quarter to half as much as a patient without COPD. And if you look at patients with ischemic heart disease, the likelihood of having COPD and dying of COPD is 1.5 to 2.5 times that of a person with ischemic heart disease who doesn't have COPD. In short, COPD worsens ischemic heart disease risk, occurrence, and outcomes. And ischemic heart disease, if accompanied by COPD, increases the probability of having COPD, but also increases the chance that you will have a serious exacerbation and die of a COPD exacerbation. And the same is true of the other comorbidities listed here: heart failure, atrial fibrillation and flutter, diabetes, and pulmonary hypertension. So, COPD and comorbid CVD occur more frequently together than in the general population. As already mentioned, they have several common risk factors, they have common pathological processes, they have common clinical signs and symptoms, and they act synergistically together as negative prognostic factors. And these are some of the studies. I don't need to go into these because we've already discussed these, but COPD patients are more likely to be diagnosed with CVD, cardiovascular disease, with strokes, and with diabetes, as already mentioned. But I wanted to call your attention to the second column here, where you look at even young people, 35 to 44, have a significantly higher risk of having COPD. And if you have COPD, of having one of these comorbidities that we are talking about, and this starts between 35 and 45. We usually think of patients with COPD as those who are 45 and over. But remember, this is a younger population who get affected even faster when they have the comorbidities.
So this is Vikram from Lupin.
Yes.
I'm sorry, we are not getting the full screen. I think probably you need to adjust your screen once.
You may have to just shut off the gallery because the full screen should be coming through.
Okay.
How much of the screen is not coming through? If you just change it to a speaker view or even less, you should be able to see the whole screen.
Okay, right.
Are you seeing the whole screen now? When you shut down the top right-hand corner? Because I'm seeing the full screen on my...
Okay, right, sir.
Okay?
Yep.
Right,
Please
so
continue.
cut off the gallery view, you should be able to see it.
Sure, sir. Thanks.
Right? Okay. So if you look at the selected cardiac comorbidities, this is a very large meta-analysis of various studies that looked at heart failure prevalence, ischemic heart disease prevalence, and arrhythmia prevalence. And you can see that it goes anywhere from about 4% to up to 64% for the various conditions, right across all the developed world. And this I've already mentioned. In patients with CVD, cardiovascular disease has about a 20% occurrence of COPD. And in patients with COPD, there's anywhere from a 10 to 60% incidence of ischemic heart disease. And if you have an acute exacerbation, the chances that the person will have an acute coronary syndrome is even higher. And you can see the last two lines there, the risk of having an acute MI, the increased risk ratio was 2.5 times plus, and the increased stroke risk was almost twice that of a person who did not have COPD, an acute exacerbation of COPD. So in short, COPD and CVD affect each other, and cardiopulmonary comorbidities are associated with the risk of suffering from frequent exacerbations and of suffering sudden cardiac deaths. If you look at the symptoms, unfortunately, a lot of the symptoms are coexisting, and these can therefore cause confusion when a person comes to you with an acute exacerbation of COPD and the person actually has an exacerbation of a coexisting non-respiratory disease like hypertension or heart failure or a pulmonary embolism, this is often missed. Similarly, when a person goes in with congestive heart failure and they have coexistent COPD and they have an acute exacerbation of the COPD, that can often get missed in a patient with heart disease. So it's very important that we look for respiratory problems in the patient with cardiac disease and cardiac problems in a person with respiratory disease. And as I said, many of the symptoms are common to both these conditions: chronic dyspnea, reduced exercise tolerance, fatigue, tiredness, and taking an increased time to recover after exercise. And since these occur in both conditions, you have to look at other signs and symptoms and investigations that can help you tease out which is the cardiac problem, which is the respiratory problem, and how much each is contributing to this condition, to the present situation of the patient. There are some direct effects of COPD on the cardiovascular system. Pulmonary hypertension, very common. It's usually mild, but sometimes can be moderate. And the presence of pulmonary hypertension worsens outcomes very, very significantly, even if it is mild to moderate. It doesn't have to be severe. Right ventricular dysfunction occurs early. As already mentioned, dysrhythmias occur. And the particular dysrhythmia that all pulmonologists are familiar with is the multifocal atrial tachycardia, which is very characteristic of COPD. And of course, coronary artery disease. And when a person has left ventricular dysfunction, it has a negative impact on exercise tolerance. Patients with COPD have a very high incidence of anxiety and depression, as do patients with cardiac disease. The diffusion capacity falls and they end up quite hypoxic, which aggravates the heart disease. And of course, the right ventricular function through something called the reverse Bernheim effect has an effect on left ventricular function and left ventricular flow, worsening ischemia. So we have a cardiologist view and we have a pulmonologist view, and we need to look at both. The cardiologist has to, when he's looking at the heart, please look at COPD. Both are characterized by older male smokers. Both are associated with worse comorbidities. If they have a lung disease, they tend to have worse lung function if they have lung disease. And if they have COPD and heart disease, they tend to have worse heart disease. And there is an increased risk of mortality from both these conditions. So having learned this, what can we do about the COPD cardiopulmonary disease continuum to offer integrated care? First of all, we need to look at what is the root cause of the COPD and the cardiovascular disease. In short, we need to target tobacco use. In those who have not started smoking, we need to strenuously work that they don't start. And those who've already started, we should try and get them to stop. Importantly, we need to target indoor and outdoor air pollution, and we need to work towards this as a community with advocacy for cleaner air, working with the government and non-governmental organizations to reduce the exposure, especially of the innocent household worker, the innocent lady cooking at home with poor ventilation. When a person has one of these conditions, we need to look for the comorbidities, look for cardiovascular disease in patients with COPD, and look for COPD in cardiovascular disease. Having recognized it, we need to reduce the inflammation, the pulmonary inflammation, as well as the systemic inflammation. We need to prevent exacerbations, and we need to use more cardioprotective medication in patients with COPD. And that's something that's often neglected. And I'm going to be talking more and more about these in the next part of my talk. This is one nice study which looked at the effects of smoking intervention on almost 15-year mortality. What they did was they took patients with early diagnosis of COPD who were smokers and looked at the special interventions of the tobacco cessation clinic to reduce tobacco use. And you can see those who received the special intervention, that is the clear bars, had a reduced rate of death per 1,000 patient years compared to those who were just treated as usual, who received standard care. Whether you were talking about heart disease, you're talking about cardiovascular disease, you're talking about lung cancer, you all are talking about all other cancers, respiratory disease. Every one of them had a significant reduction when you intervened early rather than late. So it's very important that every patient who comes to us, we need to ask about tobacco use, ask especially early, even before they develop COPD, so you can intervene. And if anybody comes to you, please ask the question and intervene to reduce or stop tobacco use. We conducted a study of 500. This is my former postgraduate, now a respected rheumatologist in Pune, Dr. Gayatri Ekbote. This was her dissertation for her DNB. We looked at 500 plus patients with cardiovascular disease admitted to the cardiac section of our hospital and assessed them for the presence of COPD. And you can see that 23% of patients had COPD, much higher than you'd expect from the BOLD study or indeed any other study of COPD prevalence. And what was surprising to us is the next slide, where you looked at patients in all stages of COPD, whether you're looking at group A, B, C, or D. There was a high prevalence of patients who had cardiovascular disease, varying between 20% and 30% plus. And this was especially common in patients who did not have very serious symptoms, who did not have frequent exacerbations, the group B category. And this tells you that when they have a lot of exacerbations, they come to the attention of doctors, but we need to go out and find them in the earlier stages, group A and B. And you can see that this low risk group accounted for exactly 50% of those with heart disease. So 50% of those with heart disease actually have a low risk of exacerbations, and another 50 have a high risk of exacerbations. And if you look at their pack years of smoking, obviously, the more severe the disease, the more the chances of COPD. But surprisingly, those who just had 0 to 9 pack years and 20 to 29 pack years, less than the 30 pack years we often use as a cutoff, had very significant occurrence of both COPD and heart disease. So you don't need to smoke very heavily to have COPD and comorbid cardiovascular disease. You get it at an early stage itself. And it was not just cardiovascular disease. A lot of them had not just cardiovascular disease, the top left-hand graph, but many had cerebrovascular accidents. A lot had peripheral vascular disease, and many had combinations. In fact, patients with combinations of cardiovascular, peripheral vascular, and cerebrovascular disease, almost 50% of them were there in the COPD group. Patients who had only one had much more of no COPD at all. COPD patients tended to have more than one cardiovascular complication. So what do we do about it? Recognizing that we have to look for comorbid cardiovascular disease in patients with COPD, which many of us do, but also you need to look for comorbid COPD, and this is something we need to alert our cardiology colleagues to look for, and we need to get involved in their care. So you look at the drugs that are available. We have 3 main classes of drugs, inhalers, in the treatment of patients with COPD. We have long-acting antimuscarinic agents. We have long-acting beta agonists, which are usually combined with inhaled corticosteroids, which form the third group, inhaled corticosteroids. And most often these days, we tend to use combinations. It's very unusual to find a patient receiving a single drug, though that is part of the treatment algorithm that has been given to us by the GOLD strategy plan. So if you look at patients who are on LAMAs, it seems to improve lung function, and this has been shown by various studies. It reduces the risk of severe exacerbations by 28% compared with the LABA alone. It reduced on-treatment mortality by 16% over 4 years. And it improved quality measures of life, dyspnea, transitional dyspnea index. It improved the health status score as measured by the St. George's Respiratory Questionnaire. And it improved exercise endurance as measured by multiple things, including the 6-minute walk test. So LAMAs make you feel better, they reduce exacerbations, they improve lung function, and they keep you living longer if you have COPD. And this was a study comparing tiotropium with salmeterol. And very clearly, tiotropium did better than salmeterol used as a single drug. And this was the results of the POET COPD study, where there was a 17% risk reduction when compared to salmeterol alone on exacerbations. But when you combined a LABA, salmeterol, with an ICS, it worked just as well as tiotropium in reducing exacerbations. So over 2 years, you can see the ratio rates were practically the same. The p-value was not different between tiotropium and a salmeterol fluticasone combination in reducing exacerbations, both in the overall group as well as in those with a high risk, that is the group D and B, the C and D groups in the current COPD classification. You look further at a triple combination when you introduce inhaled steroids, or a double combination of an ICS LABA. This was the IMPACT study, which was just published a couple of years ago. When compared with a LABA-LAMA combination, in this case, vilanterol and pneumoclidinium, whether you were a frequent exacerbator, that's the right-hand part of the graph, or a not-so-frequent exacerbator, the triple combination significantly reduced the number of exacerbations as compared to the ICS LABA combination alone or the LABA-LAMA combination. But in the higher risk group, those with 2 or more exacerbations the prior year, ICS LABA and the triple combination worked much better than the LABA-LAMA combination, which now is the basis of why we use a triple combination in group D, and we can use it in group C. Those who have the frequent exacerbators are benefited by an ICS LABA combination or a triple combination as compared to a LABA-LAMA combination alone. It also showed that not only exacerbations were reduced, but not surprisingly, the mortality also came down. So the probability of an event was much higher with the LABA-LAMA combination than when you introduced inhaled steroids. And you can see that once you introduce inhaled steroids, whether you had an ICS LABA combination or you had a LABA-LAMA ICS combination, a triple combination, there was a significant reduction in the probability of mortality in this group. So ICS seems to play a very significant role in inhaled corticosteroids in reducing the risk of exacerbations and reducing mortality in patients on this inhaled steroid. So they looked further at this triple combination, and the interestingly named Trinity, Trilogy, and Tribute looked at this triple combination. They've used a fixed triple combination. They've used open triple combinations. They've compared that with tiotropium alone. They've compared them with the LABA-LAMA combination, and they've compared them with the an ICS LAMA combination, and all kinds of combinations. They looked at the rate of moderate to severe exacerbations. They looked at lung function, the pre-dose, the trough FEV1, and they looked at the post-bronchodilated FEV1. They looked at quality of life or dyspnea index, and they looked at the moderate to severe exacerbations. And you can see in this slide that when you used a triple combination, there was a significant reduction in the exacerbations when compared to an ICS LABA combination. When you compared them, the BDPFF is formoterol with budesonide, and the addition of a LAMA helped. And the same thing happened when you compared them with tiotropium alone. And again, when you compared them with just a LABA-LAMA combination like indicaterol and glycopyrronium, the triple combination did better. So we were able to reduce the risk ratio to by almost a quarter in patients who received an inhaled steroid as part of their combination, but even better when they received a triple combination. So in short, inhalers reduce exacerbations of COPD, inhalers reduce mortality, whether you're using a LAMA alone. When you use an ICS LAMA combination, it's even better, and even better when you use a triple combination. And this is something we need to keep in mind, that in patients who have frequent exacerbators, especially, a triple combination works better, and we need to follow the gold suggestions. But it's important to remember that bronchodilators don't only reduce exacerbations, they seem to offer a better survival. And this is particularly when you look at whether you're looking at ICS, you're looking at any ICS combination, they seem to do better than, offer better survival than patients who are on other conditions. And this benefit seems to be lost in heavy smokers, in patients with diabetes. If you compare all those, in all these groups, there is a significant improvement when you have a triple combination. That's shown when you specifically look at myocardial infarctions and COPD mortality according to the treatment regimen. And the ICS LABA triple combination works best of all when you look at mortality benefits and deaths from COPD. So this is a paper published by one of my old consultants, Brian Lipworth and team, long ago. So this is an old study, and this is before the newer combinations came out. But it's not just respiratory drugs that reduce mortality. Statins reduce mortality, and both these forest plots show you that there's a very significant benefit when you use statins in patients with COPD in reducing mortality. And this is particularly true in reducing cardiovascular mortality. Strangely, it also seems to reduce respiratory-related mortality very effectively, and perhaps also cancer-related mortality. All-cause mortality definitely seems to come down when you use statins in patients with COPD. And this seems to work best of all in patients who have a high risk for cardiovascular disease. The StatCope trial is often referred to when patients try to debunk the use of statins in patients with COPD. But I'll remind you that all statins did was tell you that the number of acute exacerbations did not come down when you added simvastatin. And this does not refer to overall mortality. The other group of drugs that we commonly use in patients with cardiovascular disease is the beta blockers. And when we have patients with COPD, I myself have been guilty of this till a few years ago, till these studies came out, denying patients the benefit of beta blockers, thinking it would exacerbate their COPD. And it's very clear that COPD is not significantly exacerbated by beta blockers. COPD, in fact, some studies show that the acute exacerbations seem to come down when patients are put on beta blockers, though this is still controversial and not very clear. But what is very clear is that COPD mortality comes down when a patient with COPD is put on beta blockers. And you can see this forest plot, which shows you a very, very clear benefit. In fact, if you look at the overall effect, it's highly significant. And the rate ratio has come down by almost 30% or more than 30%. And this is true even of this very early review as long ago as 1982, which showed that whether you're looking at patients with COPD, patients with heart disease, CAD, with heart failure, and with other diseases, in all of them, there was a significant benefit by the addition of beta blockers in patients with COPD. So, COPD drugs help reduce exacerbations and mortality of cardiovascular disease. At the same time, cardiovascular drugs reduce exacerbations and mortality in patients with COPD. We are all familiar with the downward spiral in COPD. A person with COPD has lung inflammation, they have mucus hypersecretion, that leads to airflow obstruction, they get exacerbations, they continue to smoke, unfortunately, they have impaired mucus clearance, exacerbations, more lung damage, they get hypoxemic, and at each stage, their exercise tolerance is getting worse and worse. As they exercise less, their muscles get weaker and weaker. They have sarcopenia, both because of the direct effect of COPD and systemic inflammation, as well as their reduced exercise capacity. So they have muscle atrophy because of lack of exercise. And having been confined in their exercise tolerance to home, they get more and more depressed. Some of them tend to smoke more because of that, and their COPD gets worse and worse. The same kind of downward spiral occurs in cardiovascular disease, where they limit their activity because of chest pain or breathlessness. That worsens, increases their weight. They become more unfit. They stop even further activity and exercise. They fear pain. They become more depressed, and they start getting chest pain during normal daily activities. And inevitably, this leads to death fairly soon. And you must remember that the functional impairment in COPD, something we don't realize, is very considerable. At work, practically all patients reported work limitation and very significant social limitation, much more than in asthma, diabetes, or hypertension. COPD significantly impairs work abilities and the quality of life compared with other chronic illnesses. So please look for CVD in patients with COPD and vice versa. We recognize that there's a downward spiral in the combined cardiopulmonary disease. But what we can do is improve their COPD, give them bronchodilators and inhaled steroids, reduce the hyperinflation, reduce the dyspnea, improve their exercise capacity. They perform more daily activities, and that improves their training effect. They get more self-sufficient and self-confidence, and this improves something called mastery, which we're talking about more and more these days. Their social isolation and depression comes down, and their overall health-related quality of life improves. They certainly seem to live a little longer, but even more importantly, they have more life in the years that they have left. And this is a very important thing that we need to do. Get them into pulmonary rehabilitation early, get them into palliative care early, not at the end stage, but as soon as they become symptomatic. So I'll end with a few key messages. COPD is preventable and treatable. It needs early diagnosis and intervention. It's characterized by comorbidities and systemic inflammation. In patients with CVD, please search for COPD. In patients with COPD, please search for cardiovascular disease and cerebrovascular disease and peripheral vascular disease. All bronchodilator combinations help reduce COPD and CVD mortality. The ICS-LAVA combinations and the triple combinations seem to work best. Beta blockers and statins reduce COPD mortality, especially in the high-risk groups. And please consider pulmonary rehabilitation and palliative care in all symptomatic COPD patients. I'll stop at this point. Thank you all for a very patient listening, and hand it back to the organizing team.
So thank you very much for the wonderful presentation, sir. And now we'll go for the next program, sir. That is question answer session, which will be coordinated by Mr. Vikram Sopti. Vikram, over to you.
Thank you, sir. Thank you, Prashop, sir. So there are a few questions. I have total of 7 questions.
Yeah.
The first question is, when we speak about beta blocker, so is it any beta blocker, or there is any specific set of beta blockers that you recommend in the patients?
Okay, that's an excellent question. Strictly speaking, most of these studies have been done with metoprolol, which is a reasonably cardioselective, but not a completely cardioselective beta blocker. I tend to use more of bisoprolol and nebivolol, but we must remember that there are not many studies with bisoprolol and with nebivolol. There are far more studies with metoprolol. If a patient with ACO comes to me, the asthma COPD overlap, then I tend to switch them to either nebivolol or bisoprolol, because we know that the asthmatic component can get worse. But in patients who don't have an ACO and are pure COPD, I think it doesn't really matter. I certainly would not use a non-selective beta blocker like propranolol. We know that one of the best drugs to use in congestive heart failure is carvedilol. So you can give them a trial of that, but if their breathlessness seems to get worse, then I would make a switch to one of the cardioselective and perhaps the highly cardioselective beta blocker, like, as I said, bisoprolol or nebivolol, though metoprolol is not a bad choice.
Right, sir. Second question is, when we speak about ICS-LAVA being started off with the patient, what is your recommendation? We should be at least starting with ICS-LAVA as we have been doing with the pen over the practice for the last 10 years?
No, I think we need to clearly, that's a very important question again. And we find that most patients have been using and been put on ICS-LAVA combinations. And this is really not logical. I think there's a lot of thought and evidence that has gone into the current GOLD recommendations. And it's very clear, group A, less symptoms, less exacerbation risk, which means less overall risk, use only symptomatic treatment because they have short-lived symptoms, few symptoms. They don't need to be put on any long-acting bronchodilator. And because they have few exacerbations, they don't need to be on inhaled steroids. Group B is an interesting group because these are patients who are more symptomatic, and we tend to use a single or a combination of long-acting beta bronchodilators, either LABAs or LAMAs. Since they have few exacerbations, inhaled steroids may not have much of a role. However, this is a group you must consider using a double or a triple combination, including an inhaled steroid, in certain groups. Those who have an ACO kind of presentation, those who have eosinophilia, the cutoff is variable, and those who have maybe high phenos or have a very definite history suggestive of an allergy-related problem, like allergic rhinitis and so on. So these three groups, I would use inhaled steroids very early. In the others, I would try either a LAMA, first choice, a LABA, or a combination of LAMA-LABA. The group C is where it is left to you. You can use an ICS-LABA combination, though more often what they continue to recommend, because LAMAs reduce the exacerbation risk. Also, you can try a LAMA-LABA combination, but you can also try an ICS-LABA combination. And where ICS really comes into its own is in group D, those with more symptoms and more risk. So if I had to say this very simply, I'll say ICS definitely in group D. Consider them in group C and maybe also in group B if you have definite second indications, not just COPD, but there's one more indication, such as a frequent exacerbators, group D or group C, or you have eosinophilia or you have ACO. The kind of ICS, I leave to your choice, whatever you're comfortable with. Many people are comfortable, both patients and doctors are comfortable with, an SF combination, salmeterol fluticasone. Many are comfortable with the formoterol fluticasone combination. Many are comfortable with the formoterol budesonide combination. And more we are looking at the extra fine BDP combinations. You can also use a triple combination, and there the LAMA can either be glycopyrronium or tiotropium. It really is your choice. All of them have shown beneficial effects, and I don't think we have a reasonable head-to-head comparison between any of them. Though recent studies, smaller studies, seem to indicate that the extra fine particle seem to have some benefit. This is not adequately shown across all studies. So still, we have to wait for more evidence in that area, and I would leave it to you to decide whatever you and your patient are comfortable with.
Okay. Sir, next question is, there has been a lot of noise on smokers COPD. What is your suggestion in smokers COPD, particularly the patient with having a history of more than 10 packs per year? So is it an ICS-LABA to start with? If yes, then which should be the preferred ICS-LABA in that case?
As I was just saying, I think there's not enough evidence whether it's a smoker, non-smoker, less smoking, more smoking. Somebody who has less pack years and is quite symptomatic is very likely to have the ACO combination. So in such a group, I would probably very clearly look for the allergic component. And this kind of patient, I would definitely start on an ICS early rather than late. So I think it really depends on whether you're really able to establish whether a person has an allergic component or not. And if a person does not have much of noxious fume exposure, smoking or non-smoking, or is more symptomatic than the number of pack years he's smoked, you mentioned 10 pack years or less, then these are patients certainly you must consider using an inhaled steroid early.
So one interesting question in this current scenario wherein we have right now the COVID moving across, big buzz for us. So how do you help, how best we can evaluate a patient, because PFT is going to be trouble for us. Any kind of test what we are going to do, the lung function is going to be a bit challenged because the patients might not accept. So what do you recommend, sir?
Yeah, I was hoping someone would ask that question. In fact, I didn't touch on COVID at all because I wanted to reserve it for the question answer session. The first caveat, I have not seen a single COVID patient myself. We've had much fewer than Mumbai or Delhi or Chennai and Bangalore. And practically all of them have been until yesterday going to the government hospital, Victoria Hospital, who are doing a fantastic job of looking after them. So I cannot claim personal experience. So let that be the first caveat I must introduce. But we have been doing lung function tests and we've been trying to limit it and not do it unless it's absolutely essential. Somebody who's having, for example, thoracic or cardiac surgery, and it's important to evaluate their lung function. In those patients, we make sure that we're doing it only after thoroughly ruling out the possibility of COVID-19. I personally prefer doing the impulse oscillometry because that is certainly less likely to generate aerosols than spirometry, for example. So we usually use a combination of a 6-minute walk test to make an assessment. If the person does the 6-minute walk test very well, is able to do the 6-minute walk test, for example, when he has comorbid CVD, and we want to not cause a problem with angina, then I prefer to use iOS, and very rarely do we actually do spirometry. And when we do spirometry, the technician does it with full PPE, and we usually try to do it towards the end, and we make sure the room is, just the technician and the patient, and the room is cleaned down after that. So yes, you have to sometimes do spirometry, but do it with all precautions. If you don't want to do spirometry, you have to try and make a diagnosis by purely clinical means. And this includes, of course, a questionnaire based on symptoms. You look at radiology, which includes both chest X-ray and, if necessary, a CT scan. I'm not recommending you do a CT scan for anybody, but if a CT scan has been done for the associated disease, please look at the CT scan. And if it shows obvious COPD, it may be worthwhile skipping the lung function test for now and straight away going to treatment. So those are the things we do. And remember that since COPD is predominantly a small airways disease, impulse oscillometry, if you have access to it, is particularly good at picking up this condition.
Right. So next question is from Tiruvala. Can FINO be of any benefit evaluating the, evaluating the eosinophilic inflammation?
Yeah, certainly. I think, there have been mixed views in India on the usefulness of FINO, but we find it particularly useful. We tend to use a cutoff of about 25. And if a person, in fact, one of my former postgraduates who is now in Kerala, I'm not sure where she is. She was in Rajgiri, now she's moved out. I think she's in Kochi, Dr. Sri Lakshmi Pillai. She did a study on FINO in the assessment of ACO and used a cutoff of 22.5 parts per million and found it particularly useful in patients with COPD to recognize the presence of ACO. And patients did very well with inhaled steroids in this group. So yes, FINO I think is useful. I didn't mention it because too many people don't have access to it, but we have used it. I use it a lot. And as Dr. Sri Lakshmi Pillai showed, it is extremely useful in separating COPD from ACO and asthma.
So one last question. In fact, in the patients with diabetes who are on OHAs, they require high dose ICS. Would you recommend them to be switched to insulin for the better control?
Almost no patients with COPD need high dose ICS. That's something I would like to make clear. Very few patients, in asthma, I would push inhaled steroids to medium to high dose if necessary and try and bring it down as soon as possible. Remember that there's a dose response curve which flattens out at approximately 500 micrograms of fluticasone. And I'm at pains always to point this out to colleagues. Please do not use combinations which take you up to 1,000 micrograms of fluticasone or 3,200 micrograms of budesonide, because you can reach that very soon when you're prescribing inhaled steroids. I try not to exceed 800 micrograms of budesonide, and certainly don't go above 1,600 micrograms of budesonide. I try never to exceed 500 micrograms of fluticasone. So most patients with COPD don't need higher doses than that. The debate on which inhaled steroid to use is interesting because fluticasone is a very potent steroid. It certainly has some advantages because it has very high lipophilicity. It stays in the lung longer. It stays in fatty tissue longer, which means the systemic bioavailability is less. But it also means it's released very slowly from fatty tissue, so its effects may last longer. And some people believe, without adequate evidence, that it may exacerbate diabetes. I remember at a meeting that I was at, one of the consultants, whose wife is a diabetologist, was very clear that he would not use fluticasone. On the other hand, we know that fluticasone is almost definitely associated with the higher risk of pneumonias, and multiple studies seem to have shown that. So when you have to use an inhaled steroid, I would look at, has a patient got frequent, has he had pneumonia before? And in that person, I would probably not use inhaled fluticasone. But I'm a great fan of fluticasone. I think it's a wonderful inhaled steroid. If you keep to the doses that I mentioned earlier, and you use them through a spacer, reducing systemic bioavailability, reducing the fraction that is swallowed, fluticasone is potent and very good with reduced systemic bioavailability. So I tend to use a lot of fluticasone in my patients with COPD. But if they've had an exacerbation, which is actually a pneumonic exacerbation and not a non-pneumonic exacerbation, then I would tend to switch them to one of the others. The other choices you have are either using extra fine beclomethasone, which is now available, or budesonide, or of course you can use the newly available ciclosinide, but that's not available in a combination yet. So, that really is not a viable option now. So I'm a great fan of fluticasone. Your choice, depends on your experience and your patient's happiness with, I've had patients who refuse to change their inhaled steroid, or when they change their inhaled steroid are very unhappy, and we switch them back.
Right, sir. These were all the questions from the audiences. I request Prashop, sir, to please take the session forward. Prashop,
Thank
sir,
you,
over to
Vikram. Thank you, Vikram. Sir, I would like to take this opportunity to thank you on behalf of Lupin Respiratory. It was wonderful to have you as our speaker for this evening, sir. It was indeed one heck of a presentation. Thank you very much, sir.
It's my pleasure. Thank you for inviting me. And thank you everyone for listening on an evening. Okay, great. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.